Okay, so I'm going to go ahead and introduce our next speaker. Today, I'm introducing Trudi Matthews. Trudi serves as a Senior Director of Quality and Value Strategy in the Office of the Executive Vice President for Health Affairs at UK Healthcare. Trudi is also the Executive Director of the Kentucky Regional Extension Center, and she is over all quality at UK Healthcare as well. So I'm glad to have Trudi here. So she is my manager, and I'm so glad to work with Trudi. So Trudi, come on up and talk about social determinants of health.
Great. Thanks, Brent. Well, I am really excited to be able to talk about a subject that I have grown to love over the last year. So just to tell a little story, about a year ago, the UK is part of a directed payment program here in the Commonwealth for universities. So U of L, UK, King's Daughters, UK King's Daughters, because they're part of us, and then Norton, because Norton has U of L's pediatric faculty, are all part of a directed payment program. Most hospitals in Kentucky are part of the hospital rate improvement directed payment program, but the universities have their own. And so Medicaid had as part of our work, decided to add social determinants of health screening to the work that we're doing under our university directed payment program. And then also too, about that same time, so we were investigating, exploring what is this going to mean for our health system. And then around that same time, the Centers for Medicare and Medicaid Services also came out with the inpatient prospective payment rule that said basically all hospitals in the country, as part of your participation in Medicare and Medicaid, we're going to have to implement on the inpatient side social determinants of health screening. So I go off to a conference. That's what you do when you're like, I don't know anything about this, but we're going to have to do this. Let me go learn about it. You go off to a conference. So I went to the Association of American Medical Colleges, which is the AAMC for big academic medical centers, is an important association for us. So I went off to this conference to learn more about social determinants of health and how it plays into different programs. And so I heard federal, representatives of the federal government talk about how health equity and social determinants of health was a core strategy that they were implementing, and it was going to be part of every single program they do. And then I heard a number of health systems talk about how they'd implemented social determinants of health and what they had learned through that. And then also a lot of different health systems that were participating in alternative payment models were like, this was the thing that helped us to really crack the cost and quality nut for our alternative payment model program. And it was like, after presentation, after presentation, after presentation, I was like, oh, this isn't just a screening that we're going to do and our health required to do in our health systems. This is a transformative part of our future in healthcare in the United States. And that was like oh, we're implementing this just as if we're adding a little questionnaire for our patients. That is not going to work very well for us. So fortunately, we have a great team at the University of Kentucky. So Jenny Jenwright and Katie Carrozza, who are here. Jenny's with the Healthy Kentucky Initiative. Katie Carrozza's with our REC team. Myself, our Director of Population Health, Jessica Sass, our Director of Case Management for our inpatient and then a number of other folks are also involved in our efforts. So we all have been huddled and working on this for over a year. And of course, like every health system, you guys are too. I don't know anymore. How many of you are responsible in some way for social drivers of health screening or anything like that in your? Okay, so a few hands out there. So I'm going to talk about what is happening nationally with this, first a requirement for screening, but it is going to increasingly be part of all of our quality strategies, because the federal government is going to make us do this, both for, I think Jessica and Vance talked about how it's playing into the quality payment program, but also every hospital in Kentucky, both Medicaid and Medicare, are going to make us do this. And I say make us, but also too, this is a great opportunity for all of us. So I want to talk about what we've learned over the last few years, but by all means, again, I feel like I'm the new kid on the block. So I'm going to share our experience, but also too, I'd love to hear from each of you, because this is really what we'd like to try and do, is form kind of a learning community around this, because it really is such a transformative part of the future of our health systems in the United States. So just for, that was just a little bit of back, I'm going to talk about do a little bit of level setting in terms of why is the federal government so interested in this? Do a little bit of a literature review and survey, because as an academic medical system, we can't do anything unless we kind of look at what the literature and published studies say, right? That's part of being UK. Talk about our screening workflow and just share our experience, what we're doing in terms of staff training. Maybe that'll be helpful to you and to what you're doing. And then I'd love to hear from you, your thoughts on how you've done things differently, maybe. Also talk about engaging community-based organizations, CBOs, in the work, because I think that really is where our next frontier or challenge, once we get the screening implemented, is then how do we work with our community-based organizations to actually close those gaps around social needs. And then certainly I'd love to hear from all of you as we're doing that. One question, I love the HOVA, how does one say that? Like the app that we're using for the meeting, somebody already asked me a question on it. So I'm going to answer that question while I'm talking today. I love that. I love technology. It's so fun. Okay, so let's talk about level setting. So again, what's the background behind all this? Why is this such a big move? Why is it being embedded into every grant, into every healthcare program that the federal government pays for? And I will say, it's easy to want to say, oh, this is just a Democratic thing. The Democratic administration is driving this because, if you're more right-leaning, you'd say like, just a bunch of bleeding hearts, they're doing this. But what I will say is, regardless of your party affiliation or where you are in the political spectrum, this stuff matters for a couple of, for some reasons I'm going to talk about here. So let me back up and say, all these things, I use social determinants, but we, with our public facing work, talk about social drivers of health. I use them interchangeably. Our communications folks are like, determinants is too long of a word. It automatically puts you above the 8th grade reading level because it has so many concepts or so many syllables in it. So we're going to use social drivers of health. So at UK, we talk about social drivers of health, but it's all the same thing, whether you say social needs, social determinants, et cetera. So first of all, absolutely, every one of us have to be concerned about meeting our regulatory requirements. So for all of us, it's part of our the hospital rate improvement program. It's part of for us as university providers, we have to implement it in our ambulatory primary care clinics, both for adults and pediatric patients. And then we also have the CMS requirement in the inpatient prospective payment rule that as of January 1, we need to be screening people. What happened? We lost slides. Okay, I'm pausing. I'm pondering. So, but one of the questions that was asked in the app was, has UK integrated what it's doing related to its inpatient requirements from CMS with what's required for the Joint Commission? And I would say absolutely 150% yes, we did that, because who wants to do 3 different things for 3 different regulatory bodies, right? So we integrated actually what we're doing for Medicaid, for hospital inpatient quality reporting, as well as what we're doing with Joint Commission. And we encourage everybody else to do the same, because it's just a whole lot of work out there, and might as well try and align that work. And we'll talk about how we're doing that. Obviously directly supports regulatory requirements. It's an integral part of, for us as a large health system, our mission as UK is to advance Kentucky, and UK Healthcare and UK King's Daughters are about creating a healthier Kentucky and advancing the health of Kentucky. And so this is part of that. Also too, I will say, one of the things I learned from other health systems that are farther along the road is that social drivers of health are a key component driving a lot of our healthcare costs. So there is this, in published studies, it's frequently seen that about 5% of patients are responsible for 50% of costs, and about 20% of patients are responsible for 80% of costs. And so when you break out those healthcare costs, obviously end-of-life care is a big part of that, but also individuals who have unmet social needs tend to have a lot of costly complications. And so think about, for us here in Lexington, our homeless population, a lot of repeat folks coming in and out of our EDs, and their care is not managed well outside once they leave because their lives are just so unstable, right? So if you can help connect them to community-based resources, have help with housing, with other types of needs, there's the potential then to drive down some of the care that they might have been receiving, those repeat visits to the ED, for instance. Also too, one of the things that is, I'm going to go on to the next slide. One of the things that is also part of published studies is that overall, we as clinical care providers are really responsible only for about 20% of any individual patient's total health. The rest of the 80% are other factors outside the clinical care system. So if we're interested in really whole person care, whole health of our patients, if we only focus on making our clinical care systems as great as they can possibly be, we'll only really be impacting 20% of a patient's total health. The other things are things like physical environment, health behaviors, and then 40% is related to social and economic factors. So clearly 80% of that total, kind of 10 plus 30 or 10 plus 30 plus 40, there equals 80. 80% of a person's total health are those other factors that are outside the clinical care setting. So let's talk about what we learned from the literature review. Because again, as an academic medical system, we can't do anything unless we look at the published studies. So we did this work for you, so you don't have to. How about that? We're sharing it on. So this is all the studies that we looked at related to where social drivers of health screening was being done and follow-up. So some things that we learned through that process. Again, just to reemphasize, these social drivers of health play a big role in overall health for patients. They also influence greatly healthcare risk. Remember Jessica talking about those HCC scores, utilization and per capita cost. So again, that if we're ever going to get healthcare costs under control in the United States, part of what we have to do is really understand that other 80%, right, that are driving unnecessary spending, right? I'm not just, I care about the whole person, but also too, healthcare costs a lot in the United States. Connecting patients to resources can lead to healthcare savings and improved outcomes. Now, that's where the literature is not like, it's not a direct line, like you screen, you follow up, therefore there will be lower costs. It's not that direct. There are a lot of things that go into that. I'm going to share a little bit from the literature, what is part of that. And then also, I think part of the recognition is that even for a big system like UK healthcare, UK King's Daughters, we have case managers and others who work around social needs, but in our individual clinics and our individual hospital units, that's not what our clinical care teams do, right? This seems very foreign to them. So implementing this screening has to be done in a way that doesn't disrupt the clinical care process, but also connects those patients to the help that they need. So we sat down with a lot of different health systems and said, teach us what you have done. How have you minimized the burden on your clinical teams of doing the screening, knowing that's not their expertise? They're gonna have to make sure the screening is done, but then how do they hand off that patient who has those needs to someone else for that? And so again, it's really, really important to work on that. Some other things that the literature says is that using some kind of electronic screening method that the patient does themselves usually results in a more complete screen than someone asking the questions. So we're going to talk about what are some of the questions are like do you, in the last 12 months, Have you experienced any, violence from your partner? Those are very sensitive questions, right? So people generally are willing to share that information if they're doing the screening themselves, less likely in a face-to-face question. Yeah.
Well, we will just save them all to the end.
If for? Yeah, let me ask a question.
Maybe. What about completion rate?
So obviously I don't have data from UK, but because we're just starting our pilot phase now. But from the health systems that we talked to is that their completion rates were much better. If it was done, the patient answering the questions themselves on some sort of either electronic device, or for us, we're using MyChart, that the completion rates were much higher. And I'll give you an example of where, weirdly enough, oftentimes when we implement these screenings, what I hear from clinical staff and our providers is, people aren't really going to be honest on these screenings. They're not going to really tell you what's going on. The literature actually says that's not true. They really will share this with you. Not everybody, of course, and we felt very strongly that our patients ought to have the right to refuse to answer these questions. That's their choice. They can choose to say no. I don't want to answer this question, and so we give them that option in our screening tool. But the experience of other health systems nationwide is that if you ask the questions, oftentimes you will find surprising answers. I'll give an example, not from our social determinants of health, but from our depression screening metrics. So I heard again and again from folks like that people aren't going to really answer the PHQ-9 questions honestly. But I'm telling you, I have story after story of once we implemented depression screening of how many people answered honestly the question, are you thinking of hurting yourself? Do you have a plan? Yes, yes. And that was the reason why we intervened, and we have saved lives as a result of that. And I'm fully convinced that also with social determinants of health screening, that we will also do the same. We will identify social needs that we didn't know about that are part of the barriers to care that our patients are experiencing. And I've heard clinicians say over and over, I can deal with their heart disease when they come to see me for their, advanced, congestive heart failure. What I can't deal with is their housing instability, their transportation issues, their utility difficulties. And so this screening is helping us in a more disciplined way look at those barriers to care that we often see, especially here in Kentucky, and dealing with them in a more disciplined way. So another kind of part of this is also that to really have what I think of as like the dynamo of doing this is not just the screening. If we do screening and we don't do follow-up, then that's not going to be great in terms of overall healthcare costs and improving overall health outcomes. And surprisingly enough, that is what the literature says as well. Engaging participants in the development of social determinants of health screening can also help identify problems early on. So we've had our patient and family advisory councils engaged. We've had community-based organizations engaged and ask them the question like, hey, we're going to be asking these questions and we're going to be referring and sending people to you. Tell us what you think about how this process works currently. Because we do a lot of this in our case managers already ask some of these questions for individuals in our inpatient setting and as well in some clinics, but just not as widely as we're implementing now. Also, so what else does the literature say? So patients and provider perceptions of screening. I think this is one of the things I heard. It's like, oh, our providers are never going to go for this. This is going to be terrible. They're going to moan and complain. And whenever you implement something new, you're going to get complaints. Let's just kind of say like, right, have you ever done anything new in the world and never gotten a complaint? Right? Is that ever going to happen? No, there's no universe where that's not going to happen. But largely, when this screening is implemented, over time, patients are glad to be asked about these things. One of the things that we've done at UK is, it feels like you have to ask a lot of questions of patients. Like our MyChart questionnaires seem really long. Me as a patient, as I'm going through those questions, like, am I ever going to get to the bottom of this, right? So part of what we've done is develop a communication campaign talking about how we care for you as a whole person. We ask because we care. So we have a video, we have resources, and we've spread it across all of our communications platforms so that patients know part of the reason why we're asking these questions is because we care about you as a whole person. We want to help impact your total health. That's why we're asking these questions. And when it's framed in that way, then patients are very, very positive about being asked these questions. Overall, clinicians also, many of them feel like I'm butting up against problems that I cannot solve for my patients. They have issues and challenges, and I don't know what to do about it, but it's impacting their overall health. I can help them again with their congestive heart failure, but I can't help them with their homelessness. And this also will help to deal with that. There also are the way that we do screening as well is really important. So there are challenges of screening and not intervening. And so if there's not good follow-up, that can be a risk. And so all of us need to kind of think through thoughtfully how to do that. And that's been a big part of our conversations and planning at UK. So again, kind of screening only without referral. This seems kind of, there are published studies that like basically you're not impacting outcomes if you only screen. And then thinking through your network of supportive services is really, really important. And there are lots of promising studies that you can really change outcomes overall if you're connected well in your community to community-based organizations. Obviously, I want to say in all these published studies, they're like, well, it kind of is dependent on how you do it. So how much did you invest in the process? Oh, hi, I didn't mean to turn off any lights. It just, there we go. It just suddenly went dark and I was like, oh no. So it depends on how much you invest in the program. It also, so there are a lot of factors that play into the overall success of some of these screening and follow-up implementations. And we want to make sure that folks know about those as well. So again, kind of I'm going to skip over the slide so I can get to the next one. So key success factors. These are the things that we looked at in talking with other health systems and that what they told us. So executive level leadership and support. And again, think about your CEO, your COO, your CFO, C-suite leadership and their makeup. You're going to have differing, when you say, oh, the federal government is making us do this, or Kentucky Medicaid is making us do this, you're gonna have varying reactions. I've had some people say like, oh, one more thing that's added to the clinical care environment that isn't really in our wheelhouse. Why are they making us do this? And so hopefully some of what I've provided today is part of the communication back. It's like, well, I even had one conversation with someone who was kind of like, this is just all, one party's view of things. And I'm just not down for that. I'm like, well, let me tell you, Senator so-and-so, who's as far left or right as can be, or this one, they're for it. Really, you can find champions across the political spectrum who are invested in this work. It's really crosses all party lines. So if hopefully that helps you in terms of if you're going to be engaging your executive level leadership. We also found too that just building the screening tool isn't enough, that we have to really standardize our processes. So we have kind of in UK, before we started doing this work, there were several clinics that had a lot of high risk patients that were doing the screening. They were doing it one way. Some of our inpatient units had also implemented social determinants of health screening related to sometimes grant projects they were working on. They had done it a different way, and the results were very variable. So having kind of bringing everybody together and saying, how can we do this together in a way that has integrity was really valuable for our organization. Definitely building a trusted relationship and conversation with patients and with community-based organizations is really important. And then thinking about the financial commitment that your organization has to make in order for this work to be successful. Again, you can do just screening. That's what's required now, but there's also follow-up to really impact total health outcomes, to really impact cost and cost drivers. There has to be some level of follow-up. Then I'm going to skip over the CBOs because that's there, but talk about patients. So working on, for us, we've had to really work on our access to our patient portal. So improving, talking with the clinics that we're implementing in and elsewhere about improving our overall MyChart usage. And then also building those trusted relationships with some of our CBOs, kind of going back to them and saying, hey, this is something new that's coming our way. Let's have a conversation about this. And then really thinking about how we maintain the integrity of our conversations with our patients. If they want to refuse to answer the screening tool or the questions on the screening tool, we want to do that. And so we've really tried to build out our process in a way that respects patient choice as a way of building trust as well. I'm going to skip over this and implement because I want to get to your questions as well. Remind me, Brent, how long do I have? Okay, all right, so I've got 20 minutes. I'm going to go through some of our screening workflows and 11:15. Okay, so because I want to leave some time for questions. I want to come back to some of your other questions. So basically in the requirements, there are 5 domains that we have to screen for: housing insecurity, food insecurity, transportation, utilities insecurity, and interpersonal safety. So that's what's required in the hospital inpatient prospective payment rule. That's what's also we've implemented in our university directed payment program for ambulatory screening that we're doing as well. So we've aligned those two so that we're doing them basically the same way. This is an example of the screening questions. I won't go through every one, but you can see there are questions on here that are pretty tough. Like in the last 12 months, was there a time when you were not able to pay the mortgage or rent on time? Under the housing questions. So again, these are sensitive questions. And, as our clinics have been implementing and our inpatient units, our case managers have been doing the screening with patients, folks have kind of, there have been some questions like, why are you asking me these questions? And we've responded, we just care about you as a whole person. And if you have needs, we want to help to meet those needs. And most people are like, okay. But I'm like, but you can, our folks are like, you can refuse if you don't want to answer that question. They're like, okay. And most people answer the questions. So in our inpatient workflow, it's mostly our case management team that are working with patients to do that screening. And we do have them asking the questions, although over time we want to move towards tablet-based responses and also using MyChart for those folks who have scheduled inpatient visits. So we don't have that quite in place yet, but for our kind of implementation for 2024 will be mostly our case management team that will be handling that, our social workers. And then every patient, whether ambulatory or inpatient, for us in their after visit summary or discharge summary, will receive information about where to go for resources. And then we've also, on the ambulatory side, as you check in and do your pre-visit work, that's where we're having that screening there. And again, folks can refuse to answer some of the questions. And then also too, if it's not completed in the MyChart page or they don't have MyChart, then when they check in and they're roomed, because we felt like it wouldn't be appropriate to answer these questions out in the waiting room for registration. We really wanted them to be someplace private. The rooming staff will hand them a tablet, and then we'll ask them to complete any questionnaires that are outstanding, and then give them the chance to answer those. And then they'll check to make sure that things are complete, and it'll be added to the chart. And then again, every patient in their after visit summary will be given that after visit summary with information. If a patient screens positive for a social need and asks for help, and that's part of the questionnaire, then they're routed. In ambulatory, they're routed to our population health team. We have community health workers that are there to help connect them to resources. And then our case managers handle anyone who screens positive and asks for assistance there. So, and if you want to know more about that, we can talk through that. I've got some more slides here that kind of go into more detail. I'm not going to cover them today because I really want to get to your questions, but they're there as resources for you in your packet in case that's helpful. On the inpatient workflow, kind of already walked through that flow as well. Then in terms of screening pathway, so once someone says, yes, I have a social need that is not met and I would like help, so it's a positive screen and they've asked for help, then they're also asked whether any of their needs are urgent. And so they kind of go through a different queue in our system based on whether the need is urgent or not. And so That's one of the ways that we're trying to make sure that specifically like with our case managers and inpatient, if there are any urgent needs, that those are absolutely addressed before they're discharged from our hospital. And then also sometimes before they leave the clinic as well in the inpatient or in the ambulatory setting. Also too, sometimes patients will say, will answer the questions like, I don't have any social needs and there's no additional follow-up, or they say, I don't need assistance. Maybe they're already maybe they have housing insecurity, but they're already working with a housing agency in their area. So they don't need assistance. Well, in that case, there's no additional follow-up, but they will get a little blurb, some language in their after visit summary or discharge summary that in case they do have needs later on, that they will know how those can be addressed. One of the things also in the literature that we found that was really, really interesting, because like if your organization is embarking on this journey, it can seem like, oh my goodness, like think of at UK, we estimated that we're going to screen around 100,000 patients in 2024. That seems like an enormous number of people to reach, even for a big health system like us. So the advantage, of course, is using electronic tools is that some of it's automated. But also, one of the things that we found in the literature that's very consistent is that of the total number of patients that are screened, only 25% screen positive. And then of that 25% that screen positive, 70% do not ask for assistance. So for us, we're going to screen 100,000 patients, but actually our estimate based on the published literature is that we're probably going to, in terms of real follow-up and assistance that's needed, is going to be around 7,000 to 8,000 patients. And that's pretty consistent through the literature. So that's a still a big number. Don't get me wrong, that's a big number, but a lot more manageable number than 100,000, potentially needing help. So we share that so that for the folks who are considering taking this on, like how do you really estimate what our volume of people we're going to have to help will be. Another thing that we've done is really we want to train all our staff across the entire health system. So we're using web-based training. We also will have at the elbow support as we're rolling this out in January. I mentioned that we have this communications campaign around why we screen, why we ask. We ask because we care. That's kind of helps with patients who are saying, why are you asking me so many questions? And then we have a lot of embedded workflows, Epic tools, things that we've added as well. Your EHR may have tools as well. And then in the ambulatory setting, we're really having that every clinical team getting that training. And then an inpatient, mostly it's our case managers, but we're providing more generalized training across the entire health system. So if that helps you in terms of like building out a training plan, how would we get this to the people that need it? We're providing that information for you as well. Then we've got some frequently asked questions and how we respond to them in case that's helpful for you. I won't go into those today. But then also too, one of the things that we felt really strongly about is that it's really important to help train our clinical teams how to respond to patient questions in a sensitive manner. Again, these questions are sensitive. And so understanding that there needs to be a conversation that is done in a culturally competent way, in a way that is respects the dignity of the patients is really, really important. And so we have training materials around that as well. So we've also engaged our community-based organizations, again, kind of reaching out to them and asking them a question like, hey, basically every hospital in Kentucky is doing this. Do you guys know that this is happening? Most of them don't. And that we're expecting that this is going to increase referrals. And this is where we really anticipate that we're going to experience some bottlenecks in the process. Our own clinical environment, we can manage fairly well, but then once you refer someone for help or give someone a phone number to call and a person to contact, what happens with that? So I think this is really kind of for us in Kentucky because so many hospitals and health systems are going to be doing this work, that this is really where all of us need to kind of learn and build together. We see that there's just going to be a lot of needs identified, and we're not sure that our community-based organizations are always going to be able to respond to all of those needs. This is going to be, we're going to be doing this. This is really a new thing. And that's kind of going back to the theme that I had at the beginning. This is not just adding a screening. This is really changing the way we as healthcare systems engage with our patients around these unmet social needs, and then how we're connected with our community and are working together with that network of community partners to meet those social needs. And again, I think that's where we're really going to grow and where we're going to see some need for additional capacity across Kentucky. Okay, I'd love to hear your questions. And I know there may be some folks who are online as well, so we may have some questions in that regard. So can I start back with you? Do you have some other questions that I didn't answer? Yeah. Yeah.
Never been told I'm too quiet before. That was great. So you have somebody who goes through the screening with their social workers. Love you guys. You guys are amazing. And it goes on to the next step. But in the midst of that, I still have, say, for example, a health literacy gap. My patient has the desire, they want the help, their hands are wide open, but they really don't understand. And it just brings me back in my mind to teach a man how to fish as opposed to giving him a fish. So are you doing anything to mitigate that as you build this pilot?
That's part of the reason why we're relying on our social workers on the inpatient side, because they really are such ninjas about navigating the community-based organization environment and helping patients. And that's really capacity that we built over the last 10 plus years because of readmission, needing to reduce readmissions and all those things. And then for our ambulatory population health team, they have community health workers who are they're specially trained to deal with those health literacy follow-up needs. And then I think that the challenge for us has been, how do we help the medical assistant who's rooming the staff, somebody is like, I didn't complete it online because I didn't understand these questions, or maybe I'm not an English speaker and this doesn't make sense to me. We're working on translating our questions into other languages just for that reason. And then also training our rooming staff to engage sensitively with folks who are not able to complete the screen because of health literacy or other challenges. So, but I would love to say like, oh, we got that all figured out. We're still building and growing. So if anybody here has the answer to that one, I'd love it. That's something where we can share, maybe grow together. Yeah. Another question, or do you have?
I don't want to hog the microphone.
Okay. All right. We'll move on to another one. Okay. Yeah. I'm going to have Brent's going to be my Phil Donahue or Oprah Winfrey hopping across.
We'll give it to you, Becky.
Does anybody remember Phil Donahue here? Am I aging myself? I know, I remember Phil Donahue.
So we're doing all of the screening and all of that. And I guess our question is how do we address all these issues after they're identified? Like the first thing we did was put together like a community resource guide of all of our service areas so that, we could distribute that to our patients. We're now doing like a partnership with God's Pantry to do food insecurities.
That's awesome.
But how do other organizations, how do you determine, now you know what the patient needs, where do you draw the line? And this is what the organization can do. And then here's where we need to partner and hand those patients off.
Yeah, that is a great question. I don't have a great answer for Kentucky yet. I think that's where we're going to grow. But I will say that some of the health systems that we talked to in Massachusetts, where they have for probably about 7 or 8 years, Medicaid has required them to do this screening, and they've had these large-scale alternative payment models that really focused on unmet social needs. What has happened in those states where they've had this type of work going on is that it becomes a lot more, your community-based organization network becomes a lot more like your post-acute network, where you're really having preferred providers and you are together working and investing in the solutions needed for your patients. So that was part of the aha for me in the conversations that we had with other health systems, and then learning from the other academic medical centers that had been doing this for, half a decade. That's about how long this work has been around. It's still very new, is that it does require, to really meet the needs, you're going to have to develop and work with your community-based organization network, a lot like you work with your post-acute provider partners, to really see those needs met. I think I see that on the horizon for us here in Kentucky. Yeah. But I love that you have that partnership with God's Pantry. Yeah. Okay. Yeah. Yeah.
Okay, sorry. And they were, concerned that we were spinning our wheels trying to help, and it's the same people going to all the
Right, right.
organizations. So what they did was develop what they call Perry County Quick Response Team.
Mhm.
And every Wednesday, there's a meeting. It's called the Situation Table. And all of representatives from all these community-based organizations and our clinic and other clinics in the area and all kinds of things, faith-based organizations, everybody comes together on a Wednesday morning from 8 to 8:15 or 8:30, and they discuss, these are what's come across, and this is critical. They need help immediately, and so every week we know what every organization's dealing with, and they bring the patient to the table as far as, this is a need, and then somebody will say, wait a minute, we're helping them with this.
Mhm.
And that really helps
I love it.
our community tremendously.
Yeah.
Because we do social determinants of health is what we call them, but
Yeah.
and we have a transportation department at Little Flower that, is free of charge. But we know LKLP has it and they charge Medicaid patients and, and that kind of thing, but some patients can't pay the $5.
Right. They can't pay the
So
copay.
I'm the CEO, but I write the grants for our clinic and all of that. So in every opportunity that HRSA allows us or whatever funder to add a vehicle in there, then I'm adding a vehicle. And
Yeah.
now we've got 5 vehicles, one handicap, we call Big Whitey, it's like a mini bus. And then I wrote for a mobile health unit that we take all around the community. So that's a way to help that,
Oh, absolutely. And I love, because as a federally qualified health center, you have the capability of really doing a lot of those wraparound services. I love that. So you can all learn from what you all are doing. Yeah, that's great. Yeah.
So, I mean, it is doable.
Yeah,
It
yeah,
takes a lot of
absolutely.
work, but it's doable and it meets the patient needs. So they will feel like, okay, I can have that mammogram. I can do that
Mhm.
Pap smear. I can, because, I mean, we've tried it all.
Yeah.
We've done, Pats, panties and Pats. We gave them all.
I love it. Yeah, right.
Yeah.
Yeah, one of the things that I think, yeah, kind of keeping that in mind is that right now, and all the requirements is that we just do screening, but we know how this works with federal requirements, right? It's like they require the screening first, and then later on the measure changes and they add the follow-up piece to it. So you can't really meet the quality metric unless you do the follow-up. So we know it's coming. And I think it behooves us now to be having, right now we're in a reporting year for 2024. There's going to be a performance metric. It's going to require follow-up. We can see this coming down. It's just going to be a matter of a few years. So all of us need to be learning how to do these things together, and again, it's because you guys are partnering, the burden is not on any one person, any one entity, right? Yeah, I love it. Really great. Yeah. Right now, it's just the universities are required under our Medicaid directed payment, but I think like the QPP measure is an indication that they're adding it to ambulatory requirements. I don't see it being mandatory on the outpatient side for a while. They've started with hospitals, and I think we'll focus on hospitals for right now and then add it later in. Yeah. My chart is part of Epic. Yeah, it's in essence, our patient portal. Yeah. Good question. Yeah.
Hold on once.
Oh, don't miss anybody else.
The social determinants or drivers of health, if the federal and state governments are requiring, or more and more, they're going to be requiring the identification of the people in need and identifying more and more people in need. Have they also developed programs to fund all these things more? Because otherwise you're going to get a bottleneck. You're going to identify all these people who have all these needs, and then we've got organizations on the local, state, and national level that help people, but is there going to be the capacity to help all these people we're identifying?
You're identifying exactly the issue that is going to be on the horizon for all of us very quickly, is that community, I mean, you know, we're a $4 billion health system, UK Healthcare and King's Daughters together. You know, we're a big organization. The community-based organizations we're working with, they're little. They have they're limited in staff. So I think for all of us, we have to think about how do we then help to provide assistance and funding to those community-based organizations? How do we also work together with the state in order to, if this is a requirement for all of us to do, how do we better coordinate the resources that come to community-based organizations? I completely agree with you. That's going to be we're going to begin doing the screening, and then pretty quickly it's going to be like, we can't really do follow-up unless we enhance the capacity of those community-based organizations. Yeah. And that's what all the others health systems around the country who've been doing this say. Like, very quickly it becomes like, oh, we're going to have to build up our community-based organizations because they're not going to be able to really improve overall health outcomes if they don't have the resources to help too. Yeah, and they're really the folks who understand housing and transportation and food insecurity in a way that we don't as a health system. Other questions? I think I can take a few more. There we go.
More of a comment or response to the previous question. I'm actually a health policy analyst with the Kentucky General Assembly. During the 2023 session, the General Assembly adopted a resolution directing the Kentucky Department of Medicaid Services to develop a proposal to modify Medicaid reimbursement rates to reflect area deprivation index scores, which is almost like a macro lens of looking at the social health needs of patients. So in your question is, the state and federal governments add these additional requirements for screening and then perhaps next for connecting individuals to the services to meet those needs. I think there is some work, at least initially, that's taking place now to reflect those requirements in some sort of payment. The hope is that addressing those area deprivation index scores in Medicaid rates might reflect the greater needs of the people in that community.
Absolutely. And I think there's also some of our MCOs who are in the room as well. I mean, they're also required under their contract with Medicaid also to identify social drivers of health, social determinants of health. And so partnering with the MCOs as well as the community-based organizations is really going to be critical. Yeah. I saw another hand.
Do we have another hand? Okay.
Are there any liability concerns associated with collecting this data if the healthcare organization knows that there's a need that needs to be filled and they either don't or can't fill that need and something happens as a result?
Yeah, I would say probably the biggest area of risk. So our compliance risk legal folks looked through our screening tool and approved it, but they definitely looked at all of our workflows for if we identify someone and part of our training with staff is if there's someone in the interpersonal safety or safety domain, if there are abuse or other issues identified, that we have a protocol that we follow up and that all of the staff it's reinforced what that protocol is. So that's part that I would say that at least that was the area where kind of the number one concern of our risk and legal folks were. I would say the second area of risk is of course around HIPAA. Is just that you have to be very careful how you're consented to share information from your patients. So you probably need to look at your HIPAA requirements. And of course, if something is treatment, payment, or operations, you can share information. But this is a little bit in a kind of a gray area. And so, one of the things that our team decided, not me, but our legal risk compliance team decided was that our social drivers of health screening would not be part of the regular medical record, but would be part of that kind of protected area that wouldn't be shared just because the information can be very sensitive. So that was part of how our team is thinking about it from a risk management perspective. Hope that that's helpful. Yeah. Yes.
Hold on one second. I'm coming to you.
So in a very rural area like we are with some of our service areas, they may have minimal or not a plethora of community resources. What responsibilities, how far do the responsibilities go with the requirements for the healthcare system who make the appropriate referrals, but the patient either cannot get the community resources or the community resource agencies are not responsive?
Right. Yeah.
And as risk manager, that's the question I have is, where do we get a break in that action, or are we going to be held accountable to the very end and regardless of what that results?
So I will be very honest, for right now, the federal and state requirements are that we conduct screening. So for hospitals that participate in the HRIP program, or who are participants in Medicare, and our report through the hospital inpatient quality reporting system, the screening is the requirement. So the follow-up piece is the piece where, it's kind of a decision of the health system, how they handle that. For us, because of our mission, we felt like we couldn't screen without doing the follow-up. And so we've added that as a component. And we also think that that's going to be required down the road anyway. So we're just getting ahead of it. But I do think we also feel like that the patient has to have agency as well. That's the reason why we're allowing them to opt out and say, I refuse to answer these questions. So that's, some people in our, in talking through that said, well, what if they really do have a need, but they're not going to tell us about it? And I'm like, we all looked at each other and said, well, that's their choice. That really is, we respect that as healthcare professionals. So that's part of it, is kind of understanding, patient agency and what they're involved with. And then, we feel like we're going to make referrals. Probably some of those are going to be dropped by our community-based organizations, and it's just going to have to be a learning process of which of our community-based organizations are really going to do the best job of helping us to close the loop with our patients. So, yeah.
So as of January 1st, will it still be just screenings or?
Yeah, January 1st through December 31st is basically a reporting only year, and it's just screening. So, and then I think it'll probably grow over time if it follows the same pattern of most federal requirements. It's reporting only, screening only, then over time it'll become a performance metric, and then follow-up will likely be added, although that's just Trudi Matthews' opinion, and how we're preparing as a health system. So others may see it differently. Yeah.
Trudy, can you tell us about the alignment of social determinants of health requirements and those and how those will align with CMS and the Joint Commission?
Yeah, so we see our social drivers of health screening as being part of our health equity and health disparities requirements. That's how we have it incorporated into our Joint Commission plans, and then the data that we get from that is also part of how we're working to close health disparities. So one of the things that we have on the horizon is to look at our readmission rates and our social determinants of health screening and kind of do a crosswalk. Are we finding a lot of alignment there? How are we, we are working on being able to stratify our quality data by race, ethnicity, and language. And so being able to marry up some of our social determinants of health screening numbers with those types of metrics. Again, that's a build that probably is into 2025 for us. But those are some of the ways that we're incorporating this work into our Joint Commission plans, or the requirement around health disparities and health equity. Yeah. That's a great question. So the requirements in the inpatient quality reporting inpatient side is that it's every adult inpatient admission every time, unless they're readmitted. Then they have kind of like, if they haven't been screened recently, you'll want to do it again, and the recently is not defined at all. So it'll be up to the hospitals to decide how frequently they would do that again. But they did say that if a patient is readmitted, you don't have to do the screening again, but it is every admission. So if someone comes in January with a broken leg and has a surgery and you conduct the screening then, and they come back, they're hospitalized for a heart attack in November, you would have to do the screening again, or at least confirm that the answers are still valid. So that's for inpatient requirements. Then for ambulatory, we just basically, it's required once a year with for Medicaid, what they've negotiated with us, but we're doing it every 6 months just to make sure that we're, it's kind of coming back up in our storyboard in Epic, through our workflow, so that we make sure it gets done once a year. Yeah. Well, thank you all so very much for your attention. And I want to make one more plug before I go, which is, for all of us, this is all still really new, isn't it? For those of you who are doing this work, some of the FQHCs in the room are like, hey, we've been doing this for a number of years. I'm like, yes. So for you guys, it's not as new as it is for some of the others in the room. So if you are interested in being part of a learning community that would work together on some of this, the REC is exploring and UK are exploring whether or not it would be helpful or beneficial to have a learning community to work together on some of the lessons that we're learning. And if that's the case, if you could message either me or Brent, whoever, is, better, and then we'll, we'd love to hear from you, and we'll figure out next steps on how to do that. Yeah. Sure.
I was trying to avoid that.
Everybody loves the money.
Are the hospitals or the facilities required to report any positive screenings to the patient's PCPs so that they are aware of the situation?
They're not required to share the information necessarily, but in the inpatient quality reporting rule, you do have to report your positive screens, and then it has to also be broken out by the 5 domains as well. So if you're interested, we could post what the inpatient quality rule is on the site as well, and send that out to folks if you want to see the
I just think
details.
it's really important for the PCP
Oh,
to be
yeah.
aware, because when they're in the hospital, their PCP isn't necessarily taking care or managing their care.
Absolutely.
The hospital is this.
Yeah.
So if they're not in the loop, they're totally left out.
Absolutely. Absolutely. Yeah.
Just going back to what I mentioned, would there not be a positive, thank you, would there not be a positive diagnosis code for positive on those, social determinants of health codes, which would be on the discharge, which would go back to the PCP for them to review then?
It should. It
Okay.
should be in the district. So we're building that in. We're building Z codes into ours, but I think different EHRs handle that differently in electronic environments. So, and whether it populates the discharge summary, that's something that you may want to look at in your own system to see whether it's flowing over to other providers of care.
Okay, thank you.
Yeah. Excellent. Well, I'm at time. Thank you for a rich discussion. This was really invaluable to hear from you as well. I love to both learn, I'm kind of sharing what I've learned, but I love to hear from you all. And then if you're interested in that learning community, please message me on the WOVA app, the meeting app. And I'd love to hear what your thoughts are. Thank you all so much.
Thank you, Trudi.